So today we're going to be talking about asthma. What is the definition of asthma? Well, it's a disease characterized by chronic airway inflammation and airway hyperresponsiveness, causing symptoms such as wheeze, chest tightness, shortness of breath, and cough, with variable airflow limitation. So how does it all come about? Well, it's important to remember that it's an inflammatory process. It can be divided into the acute and late phase. The acute phase involves mast cells that cause bronchospasm, edema, and mucus, whilst in the late phase you've got Th2 helper cells, which eventually lead to constriction and mucosecretion. What are the types of asthma? Well, there's 5 phenotypes. There's allergic asthma, there's non-allergic asthma, adult onset asthma, asthma with persistent airflow limitation, and asthma with obesity. With allergic asthma, you can expect a good response to steroids and there will be high eosinophils, whilst with non-allergic asthma, there will not be a good response to steroids and there will be high neutrophils. Causes of asthma include extrinsic factors like air pollution, maternal smoking, and genetics, whilst intrinsic factors include colds and infections. And finally, occupational asthma is obviously caused by allergens that you come into contact with whilst you're at work. But which airways are particularly affected in asthma and why? Well, it's the terminal respiratory bronchioles, and it's because they're surrounded by smooth muscle. What features make asthma more likely? Wheeze, breathlessness, chest tightness, and cough are all important symptoms. Diurnal variability is very important, as well as atopic features, a family history of the disease, and triggers such as allergens, exercise, and cold air, as well as a low peak expiratory flow rate. Features that make asthma less likely include dizziness or tingling, a productive cough in the absence of wheeze or breathlessness, a normal examination, voice disturbance, symptoms that are only with colds, and so on. Moving on to investigations, eosinophils produce nitric oxide, so a pheno test can suggest eosinophilic inflammation. Moving on to spirometry, an FEV1 to FCC ratio of less than 70% is abnormal and suggestive of asthma. We then have the bronchodilator reversibility test, where you check the FEV1 pre and post salbutamol inhalation, and an improvement of more than 12% or 200 milliliters is likely to be asthma. Direct challenge testing involves exposing the patient to provoking substance and seeing whether it causes a fall in FEV1. A final important investigation is peak flow variability, where 20% variability is a diagnostic result. There are a couple other helpful tests, such as IgE, allergy and skin prick testing, or FBC and eosinophil count. Important to know that there's no direct test that gives a definitive diagnosis of asthma. It's just based on clinical assessment. In terms of the differential diagnosis of wheeze, obviously there's asthma, there's also COPD, obstruction such as from a foreign body, anaphylaxis, pulmonary edema, cardiac wheeze, and mucus from pneumonia. What about treatment? Well, conservative treatment involves the avoidance of triggers and allergens, avoiding smoking, weight reduction, as well as breathing control exercises. Guidelines suggest that the baseline treatment is short-acting beta agonists. Then we escalate to low-dose inhaled corticosteroids. Then we add a LABA. Then we add an LTRA, such as montelukast, or we increase the inhaled corticosteroid dose, or we add an MART, a LAMA, or theophylline. How do they work? Well, beta-2 agonists work by activating the sympathetic system, causing bronchodilation and mucociliary clearance, whilst muscarinic antagonists antagonize the effects of the parasympathetic system, causing bronchoconstriction. A note about inhalers: the brown inhaler is a prevention inhaler, whilst the blue inhaler is a relief inhaler, and you can take up to 10 puffs. So, more detail on the treatment. So, SABAs include salbutamol and terbutaline. LABAs include salmeterol and formoterol, and the side effects of these include tremor, tachycardia, sweats, and agitation. And what about inhaled corticosteroids? Well, remember they decrease inflammation, and examples include budesonide, beclomethasone, and fluticasone, and side effects include oral candidiasis. Leukotriene antagonists block leukotriene receptors in smooth muscle, causing reduced bronchoconstriction. Examples include montelukast, and side effects include nausea and headache. Newer treatment includes monoclonal antibodies, which inhibit specific molecules to control severe asthma. Examples include mepolizumab, which is an IL-5 specific antibody, and omalizumab, which is an IgE specific antibody. Side effects of omalizumab include itching, joint pain, headache, nausea, and anaphylaxis, and indications include confirmed IgE-mediated asthma. All drugs on the asthma have already been used, and also continuous or frequent treatment with oral corticosteroids. What about asthma that's poorly controlled? Well, here are the definitions, where you have 3 or more days a week with symptoms or with required use of a SABA, or 1 or more nights a week with awakening due to asthma. The ACT score is an assessment of asthma control, where over 19 suggests well-controlled asthma. Specialist nurses are super important, especially with regards to symptom control, self-management, and reattendance rates at hospital. It's important to think about self-management plans, as they've been shown to improve outcomes such as through the use of self-monitoring, action plans, recognising exacerbations, and so on. Thank you very much for watching.